Ladies and gentlemen, now we have a most exciting prospect. We move on to the first debate of the day. The topic of the debate will be the place of cytoreductive nephrectomy in metastatic renal cancer, a hot topic in current day urology. We have two giants in Asian urology ready to battle it out. To conduct the debate, it is my privilege to invite Professor Srinath Chandrasekara, President-elect of Sri Lanka Association of Urological Surgeons, and Dr. Mustafa Taha, Consultant Urological Surgeons from PGH Padulla. Over to you, sir.
Thank you. Although it's a debate, it's going to be a friendly debate. I think we are all people of science, and the speakers have indicated that they're going to present the science behind it. So there'll be no fist fighting. And it's my great pleasure to invite my very good friend, Professor Hammad Ather. He's one of the most foremost figures in urology, not only in Pakistan, but in Asia. So over to you, Professor Hammad.
Thank you very much, Professor Srinath. When the scientific committee asked me for this debate, I think this debate is beyond my pay grade to enter into a debate with a legend like Dr. Mahesh Desai. So what I'm going to do is to provide you with some contemporary evidence about the role of cytoreductive nephrectomy in metastatic renal cell carcinoma. And I let Professor Desai to give you the pearls and gems and the words of wisdom on how to manage this condition. Well, conflict of interest. Yes, I have a conflict of interest. And my conflict of interest is that I'm a surgeon. Well, if you look at the data, both in the United States and UK, very similar data. The number of new patients are really related to the population. But if you look at the 5-year prevalence rate in 100,000 population, it's about 64. In fact, more or less exactly the same in US and UK. Unfortunately, our data is not as robust as in the West. And this is what I have retrieved from Globocan registry. We do see that the 5-year prevalence rate is on much lower side, but I can assure you from the practice that that's not so, and we are very close to that 64 per 100,000 population rather than what is shown here. What is more important to understand is that over the last so many decades, we are diagnosing more and more kidney cancers. And the number have increased. This is from the SEER database from 1975, 7.1 per 100,000 to 2014, where we have more than double the number. However, what has remained quite static is the number of deaths. So about the same number since in the last 45 years. Is the 6th most commonly diagnosed cancer in men and 9th most diagnosed cancer in women. And unfortunately, even now, when we are diagnosing kidney cancer not by the Gravitz triad, but we are diagnosing it on incidental ultrasound done for a gallstone, on a CT scan done for something else, we still see 17% of patients presenting with synchronous metastasis. And about a third of the patients who were initially diagnosed with a localized disease to have developed a metastatic cancer. So at any given point in time, you have significant number of patients with metastatic kidney cancer. Well, you can have a metastatic cancer, as I've said, which is either metachronous, which is developed subsequently, or synchronic cancer. The overall survival in these two groups of patients is quite different. If you look at this Checkmate 214 trial data, the survival of synchronous metastatic is about 24 months, whereas for all the other patients, it was twice as much. So patients who were diagnosed with a metastasis at the time of initial diagnosis are worse off. In 1996, I was working in Fritz Schroeder's unit in Rotterdam. And the lead for kidney cancer was Gerhard Schroeder. Gerhard Mickisch. And Gerhard Mickisch was one of the 6 people in Rotterdam, the Erasmus University was one of the 6 places in Europe who were credentialed to use what was the systemic treatment at that time, which is high-dose interleukin-2, extremely toxic treatment. And I've seen patients during my little time at Erasmus how toxic this treatment is. But this is what we used to have besides cytoreductive nephrectomy. Years later, in the turn of the century, our understanding of the VHL gene becomes better, and we are able to understand why kidney cancers are formed. And this opened a totally new era of systemic treatment, and we start targeting the VEGF, the tyrosine kinase inhibitors came up, the monoclonal antibodies, and we also found that alternate pathway of mTOR, which could be targeted to treat neoangiogenesis and cascade of events which results in the progression of cancer. 10 years later, we were able to understand the role of the programmed death and programmed death receptor and ligand and their interaction, and how can that be switched off using medications, and that opened a new era of immuno-oncology. And now we have entered into this era, and in the last 2-3 years, we now have more refined protocols to treat patients with the combination of either IO-IO or IO-TKI. Well, the cytoreductive nephrectomy remained the constant theme in the last 35 years of our quest to treat metastatic kidney cancer. Be it the SWOG study reported by Robert Flanagan, the EORTC trial by Gerhard Mickisch, and the subsequent analysis by Lara and et al. Of the SWOG study looking at the role of systemic treatment and cytoreductive nephrectomy, and indicating in that Kaplan-Meier curve that the cytoreductive nephrectomy along with systemic treatment provides a much better overall survival than the systemic treatment alone. We have entered into the targeted therapy era, and you can see all the underlined studies. The first one by Shoeri et al. Is a retrospective analysis, but all the rest are prospective studies that even in the targeted therapy era, arms with cytoreductive nephrectomy provided a much better overall survival and progression-free survival rate than the systemic therapy alone. However, the 2 landmark studies, the Carmina trial and the surgery time trial, have shed some doubts about the potential of cytoreductive nephrectomy, and I'll come to some of the problems with these 2 trials. Well, now we are in the era of immune checkpoint inhibitors, and we have quite a few studies. And all these studies have also looked at the role of cytoreductive nephrectomy. So even with immuno-oncology, the cytoreductive nephrectomy is one of the common theme. The trials that are ongoing, including the CytoKick or the Nordic Sun and the PROBE trial, are likely to going to shed some more light as to when should it better be done and in whom should it be done. Carmina trial was supposed to provide us a very high quality evidence whether systemic treatment or cytoreductive nephrectomy or a combination be used. However, it ran into trouble because the accrual was poor. 79 centers, 1 patient per center, basically indicating a surgeon's equipoise in recruiting patients or patients' unwillingness. The patients with lower metastatic burden and good risk patients were excluded, and these are the patients who are likely to benefit more from cytoreductive nephrectomy. SOTIME trial, which was basically set to see whether surgery, an upfront surgery be done or a delayed nephrectomy with the use of sunitinib. And again, the problem with SOTIME trial was that 458 patients were to be recruited, and they could only get 99 patients after 5.5 years of ongoing trial. And ultimately, it was decided that rather than looking at the progression-free survival, they would only look at the progression-free periods in 28 weeks. It's all past. We have now entered into the era of immuno-oncology. And the argument is that we have got better drugs. If you look at these trials, and these are all using ICI-based treatment, the number of patients who did not have nephrectomy is low. The highest number was the one by Motzer in New England Journal of Medicine. It has 30% patients who didn't have a nephrectomy. Whereas if you look at all the other trial, the number of patients who did not have nephrectomy was between 13 and 22%. So majority of patients did have nephrectomy even in the era of ICI. Now, I think really the question is not whether cytoreductive nephrectomy have a role or not have a role in the management of metastatic kidney cancer, but the question is when should it be done? And I think we have learned something from the SOTIME trial, and now we are learning more from the ongoing trial using the ICI-based therapy, that the immunological burden, the antigen burden before nephrectomy is wider, is broader. And this is the private or patient-specific mutations. And if you give immunological treatment at the time of patient's kidney in place, you're likely to mount a much broader immunological response than if you do it after nephrectomy. So I think what we are understanding more clearly now is that ICI is better if you give it up front and do nephrectomy subsequently. So as surgeon, we always have concern about the use of systemic treatment and subsequent surgery. However, if you look at the SOTIME trial using sunitinib or the PROSPER trial with nivolumab, exitinib use and ipilimumab, they all have indicated that surgery complication rate is not increased if systemic agents like these have been used prior to cytoreductive nephrectomy. These are some of the ongoing trials, and most of them are all recruiting at the moment. And hopefully, they'll be able to answer this question much more clearly, whether nephrectomy be done as a delayed option or as an upfront option. However, I would like your attention that in all these trials, you can see that cytoreductive nephrectomy is an active ingredient without which the recipe is not ready. So the treatment of metastatic kidney cancer cannot go without cytoreductive nephrectomy. This is the PROBE trial protocol, which was published in Kidney Cancer Journal last year. And essentially, the hypothesis is whether cytoreductive nephrectomy will improve overall survival in synchronous metastatic kidney cancer when surgery is performed after systemic immune therapy. And again, the concept is very clear that with the kidney in place, it is likely that your systemic treatment is going to mount a much broader patient-specific immunological response than once you have removed the kidney. What about non-clear cell carcinoma? And we know that from these trials like SWOG, EORTC, Carmina, and SOTIME, the non-clear cell carcinoma patients were excluded. However, if you look at the SEER database and the IMDC database analysis, it is clear that patients in the arm where cytoreductive nephrectomy is performed, and we are talking about non-CC patients at the moment, the survival is better in patients who have had a cytoreductive nephrectomy than those who did not have a cytoreductive nephrectomy. Similarly, the IMDC database analysis also indicated that the median survival advantage in cytoreductive nephrectomy arm is 16.3 months versus 8.6 months in the non-nephrectomy arm. I think before I end, I like to focus again on our region, and I think this is important that we should consider and not copy all the guidelines coming from the West. They have a different healthcare structure. But if you even look at the data coming from the West, the cancer-related spending in 2018 in the United States topped at $156 billion, which is twice the GDP of Sri Lanka and 1/2 the GDP of Pakistan. And the greatest contribution to this expense was the medical supplies and non-physician services like use of oncological agents. The per cycle cost of nivolumab and ipilimumab is close to about $21,000, and for pembro and exitinib is $27,000. The monthly basis cost of managing complications can be between $2,000 to $4,000 for Nivo and EP, and about $3,000 to $5,000 for exitinib and pembro. So, I mean, if you do cytoreductive nephrectomy after the initial ICI, you probably can give your patients drug holiday, and that can significantly improve the cost of management of these patients. So in conclusion, I must say that low volume, favorable risk metastatic renal cancer is one of the major indications for cytoreductive nephrectomy. Patients who do not require urgent systemic therapy, cytoreductive nephrectomy followed by active surveillance is an option. Patients with favorable or intermediate risk who respond to systemic therapy with stable regressive disease may consider delayed cytoreductive nephrectomy. And in some patients, quality of life cytoreductive nephrectomy can also be performed. Thank you very much for your attention.
Thank you very much, Professor Hammad Ather. Now we'll turn to the other side of the coin, the second part of the debate. That is, there's no role for cytoreductive nephrectomy in metastatic renal cell cancer. To deliver this speech, I would like to invite Dr. Mahesh Desai. Actually, he doesn't need any introduction for this audience, but I'm duty-bound. He is a mentor, teacher, researcher, actually a global giant. Over to you, sir.
Thank you, sir. Hammad bhai, this is not a debate. This is an agreement talk. Because whatever you have covered, I totally agree with that. And so I'll go a little faster because there are lots of repetition. Only few points which I will talk. Now, incidence, exactly what has happened. What is important is 45% of patients have a localized disease nowadays, where you can do a partial nephrectomy and things are much better in kidney preserving surgery. 20 to 30% have a locally advanced with lymph node or a local organ involvement. In that also, if it's a locally, you can do a surgery and take it out, and then depending upon, you can use a chemotherapy. But 25 patients have a metastatic disease, and 80% of them are clear cell renal cell carcinoma. Remaining 20%, the 80% is papillary renal cell carcinoma. So that again, depending upon the symptoms of the disease, you decide whether you want to do a nephrectomy. If there's no symptoms, then you look at the survival and you can decide whether you want to do a cytoreductive nephrectomy combined with the systemic disease. And this is a trial which is already mentioned, and both shows that the cytoreductive nephrectomy with interferon is superior or not inferior to interferon alone. And the value of nephrectomy in metastatic renal cell carcinoma has long been debated, and several non-randomized studies suggest higher rate of response to systemic therapy, but longer survival in patients who have undergone nephrectomy. And this is the trial which shows the nephrectomy with the cytoreductive the combination is better, or cytoreductive nephrectomy is better than targeted therapy only. But this was true up to 2005. Then came the introduction of the vascular endothelial growth factor receptor tyrosine kinase inhibitor and mammalian target of rapamycin inhibitor. In 2005, generated great interest in management of the metastatic renal cell carcinoma. as these drugs exhibited tumor shrinkage in primary tumor as well as metastatic site. But though there is no level 1 evidence, many studies have shown the usefulness of cytoreductive nephrectomy along with targeted therapy as against the targeted therapy alone. And then both the trial which Carmina and Certime has been already been mentioned, and UAE guideline, however, state that the cytoreductive nephrectomy may be considered for a subset of patient. So here, what is most important is a selection criteria. Those with a minimum risk, good risk, I think the cytoreductive nephrectomy is good, but with the intermediate risk disease who have a long-term sustained benefit with systemic disease, and those with a good risk disease who do not require systemic disease. So that was the EUA guideline, and this is a Carmina trial already been mentioned, and this is a 450 patient divided 1:1, and here eligibility criteria was metastatic RCC, clear cell RCC, treatment naive, and this is a MS-KCC, intermediate or poor risk. Good risk, out. And here is equally divided. He's already gone through this, and this is the criteria, but this shows that the overall survival and progression-free overall survival of sunitinib alone, 18 months has a longer median survival compared to nephrectomy sunitinib 13 months, but statistically there is no significant difference. Progression-free survival longer among the sunitinib alone, 8.3 months group, than nephrectomy sunitinib group, 7.2 months, but statistically again there is no significant difference. So here you will see the objective response, tumor objective response was 29% with the sunitinib compared to 27%. And disease control rate was 74% against 61% in nephrectomy group. And clinical benefit, if you consider, 47% compared to 36%. So not much difference. Again, they are evenly randomized. So in 99 patients in Certime trial, 99 patients were randomized to immediate cytoreductive nephrectomy followed by sunitinib, and this is again been mentioned by Dr. Hamid, and both Carmine and Cermet trial suffered certain. Now here trial reported 28 weeks progression-free rate of 42% immediately cytoreductive nephrectomy against 43% in deferred cytoreductive. However, the overall survival demonstrated significantly longer survival among the patient in delayed cytoreductive nephrectomy arm, median 32.4 months compared to immediate cytoreductive nephrectomy, median was 15 months. Both Carmina and Certime trials suffered certain changes which should be considered while interpreting this result. And this is a graph where you can see that this was immediate nephrectomy and this was a delayed nephrectomy, and with the combination. Again compared, and then there was no difference between the different treatment gram. Here the deferred, where you give hormonal chemotherapy before nephrectomy, it has a better chance than immediate nephrectomy. Again, the disease progression excluded cases has poor survival compared to the deferred and immediate treatment, while no disease progression group treatment deferred has greater chance of survival compared to treatment immediately. Overall, we can say that treatment deferred has a good survival irrespective of group, disease progression and no disease progression. Now, both trial has some problem. First, incomplete enrollment renders both studies underpowered. Second, the prolonged time between the trial concept and the regulation and enrollment and final reporting, especially with the Carmina trial. A number of additional systemic therapy have been approved for the first line of therapy in metastatic RCC, and many of these agents have been demonstrated superior to sunitinib, as Dr. Anibay said. Third, the patient population represented, this is very important, in Certime trial were mostly intermediate risk, wherein study group in Carmina trial, disease had a disproportionate number of patients with poor risk disease, which may contribute to the overall inferior outcome, particularly among the patients who underwent cytoreductive nephrectomy. Again, in Carmina trial, there was a significant crossover within the study. Large proportion of patients assigned to sunitinib alone eventually undergone palliative nephrectomy for symptomatic control. And also there were patients who were not able to receive sunitinib following cytoreductive nephrectomy. So there are a couple of trials, and here this is the important, the MSKC trial, where there are risk factor. The patient score, this IMDC score, and IMDC is very well selection criteria for randomizing both the thing. There are a couple of things, and here IMDC has criteria for a metastatic RCC is the Karnofsky performance score was less than 80%, time for initial diagnosis targeted less than 1 year, hemoglobin lower limit of normal, platelet calcium upper limit of normal, platelet count again upper limit of normal, neutrophil upper limit of normal, and favorable is zero risk, where there is no need of any chemotherapy, while intermediate risk is 1 and 2. And poor risk is 3. And intermediate also you divide into 1 and 2, and according to that you select the criteria. And overall there was sunitinib alone remained a non-inferior. And in here this is very important. The median survival for a sunitinib and cytoreductive nephrectomy and sunitinib was 31.4 months with 95% confidence level versus sunitinib alone 25 months with 95% in one IMDC risk factor. So in one IMDC risk factor, cytoreductive nephrectomy with sunitinib is better. While if in one IMDC group, while cytoreductivity group where sunitinib compared to sunitinib alone group, but this is one. The one IMDC factor group, the hazard ratio is 1.30, which suggests sunitinib and CN is a good treatment compared to sunitinib alone group. But this is not statistically significant. On other hand, other group, 2 IMDC risk factor, sunitinib alone has less chance of occurrence of event, and it is recommended at a treatment compared to the sunitinib with cytoreductive nephrectomy. Here hazard ratio is 0.65 with 95% confidence interval, which is statistically significant. Again here, sunitinib and cytoreductive nephrectomy recommended for the treatment of one risk factor. More than 2 risk factor treatment, sunitinib is recommended, statistically significant. For sunitinib alone group, more than 2 risk factor has a good survival compared to one IMDC risk group, but this is not statistically significant. Both for sunitinib and cytoreductive nephrectomy, one IMDC risk factor has a good survival compared to more than 2 risk factor. This is statistically significant. What I would like to emphasize, whatever is said by Dr. Hammad, is you have a selection criteria for the patient. You look at the tumor surgical risk, and you look at the risk of the delay because of surgery or because of the toxicity of the medicine. And that is here again overall criteria is delayed nephrectomy with this thing is better than the no treatment. So with longer follow-up, treatment with sunitinib alone was not inferior to cytoreductive nephrectomy followed by sunitinib in treatment with regard to overall survival in patient with metastatic renal cell carcinoma. Overall, IMDC intermediate risk patient demonstrated higher overall survival with sunitinib alone, that is in risk number 2, compared to the cytoreductive nephrectomy followed by sunitinib. Patient had undergone delayed cytoreductive nephrectomy, showed a longer overall survival compared to the patient with received sunitinib alone. So in conclusion, these further analysis from the Carmina trial confirm that cytoreductive nephrectomy should not be considered as standard care in a patient with synchronized metastatic RCC who requires systemic treatment. This finding will help to guide treatment decision for a certain subgroup, especially patients with only one MIDC risk factor, for which upfront cytoreductive nephrectomy may still be benefited. As Hammad Bhai said that after sunitinib, many drugs have come. And he has already discussed all the trials and the outcome. So in the end, I would like to say that nowadays, with the imaging technology, we are diagnosing, as you rightly said, cancer earlier. So there is a paradigm shift for doing a partial nephrectomy and all nephron sparing surgery. But metastatic cancer, if it is good patient factors, then radical nephrectomy is again a choice without even medicine. But if there's a risk factor, in IMDC is a risk factor of 1, there is a chance of doing a radical surgery and then followed by a chemotherapy. But 2 and poor risk, I think probably are candidate for chemotherapy up front. But if there is any complication of expecting any complication of surgery or comorbidity, then probably chemotherapy alone. Or if, because if you do surgery in such patient, starting a chemotherapy is delayed. If it is delayed, then effect will be, overall survival will be less. So in that patient, if you start with a chemotherapy, reduce the organ burden and do the delayed treatment, so that is, so what I feel is a selection criteria must be very, very appropriate to select which treatment will benefit the patient. I think we need to look at the new drugs which are again available now in our places, but again they are very, very costly. So we have to weigh how much is the benefit and the cost, and hopefully the cost will come down and then it will improve. Thank you very much.
Please take a seat, and I think we've got a little time. So with the permission of the chief organizers, we would like to open the floor for a few comments, and if not, a few closing remarks by both professors. I think true to the spirit of SLAUS, India and Pakistan have agreed to disagree, so which is lovely. So that's the spirit of SLAUS. So can I open for a few questions or comments to the floor, please? Can I ask Prof? Yes.
What I feel is whatever may be this thing, but the patient is important. Whether it is in India or Pakistan or anywhere in the world, I think we must have the clarity of the objectives, and then patient will be benefited. We all are committed to our patient.
So can I ask a question? So this is a naive question for the benefit of the younger trainees. So we've got a patient who's 65 years, who's got a T3A looking renal tumor, and there are no other problems, and he's got 2 lung mets and a solitary liver met. So can I ask this esteemed panel how one should handle it? This is for the benefit of the trainees. Can I ask Professor?
Well, if I will evaluate the tumor, what is the size, what is the metastasis, and tumor is there. As far as possible nowadays, with nearly more than 5,000 laparoscopic procedure and 2,000 robotic procedure. But I will go for a laparoscopic procedure because that is quick. Recovery is fast. So he's got a pulmonary match, so I'm going to start a chemo afterward. So I will see if the surgery, I can do it, which has a quick recovery and start this thing. So patient factor is most important in deciding what to.
Can I ask Professor Hammad, if you were to operate on this T3A in a fit guy with a solitary liver met and 2 lung mets, would you recommend to your MDT that the liver met and the lung met is also removed prior to adjuvant therapy, or would you take another course?
Thank you. I think decision making in situation like this is focused on 3 or 4 major criteria. Number one is the IMDC, as Mahesh Saab have very clearly pointed out, that you need to risk stratify your patient, and IMDC is probably one of the best tool that we have at the moment. Number two, you need to ask a question whether this patient requires immediate systemic treatment. And if he does in a situation like this with 3 metastatic lesions, I probably would not be considering any surgical removal or metastasectomy at the time of cytoreductive nephrectomy, but an upfront systemic treatment decision if he can benefit from a systemic treatment, and then think about doing cytoreductive nephrectomy as a second stage. When would you consider doing a cytoreductive nephrectomy upfront is when there is a possibility that after the cytoreductive nephrectomy, these lesions can be observed as an active surveillance rather than being treated. If they need systemic treatment, option is to go for immunological, and you have an option of combination of IO or IO with TKI as the standard of treatment now.
So, may I talk? Sorry.
Let me address Professor Desai's question.
Sure.
The imaging picture is quite definitive. So if the imaging is highly suspicious of malignancy, then probably there is no need for biopsy. If there is a doubt about whether it could be something else, then I think biopsy should always be the gold standard.
At our place, of course, we have an onco board, and after the nephrectomy, we put him on cytoreductive, we put it on chemotherapy, and then observe them after 3 months or 6 months. If the size does not regress, then we do the biopsy.
So, Professor Srinath has raised a very important question. This metastatic RCC are not all polymetastatic. This falls somewhere into oligometastatic one. This subgroup has come well in literature now, oligometastatic RCC. For them, standard of care beyond metastatectomy, there is definitive role of SPRT, radiotherapy as well. Most of the literatures now go beyond, surgery, then IO or TT combination, and then beyond that, radiotherapy also has a definitive role. Now, solitary medicine liver with T3 tumor, most probably single if the patient is operable, ECOG status is good, then I think cytoreductive nephrectomy, metastatectomy is justifiable, I think. But by and large, the role is that systemic disease should be treated in systemic therapy. That we should not forget. Thank you very much.
Thank you. Can we have one more question if there's? Yes.
I think you must also having the same thoughts. If there is a metastatic disease and there is a low volume metastasis, like say 1 lung metastasis, then you can do nephrectomy and also do a lobectomy or take out the metastasis. And that give you overall. You saw that patient which I showed you in the morning with urothelial carcinoma, non-RCC, bilateral disease and all thing, and with metastasis. But even then, because of the symptomatology, I did bilateral nephrectomy and cystectomy, and still patient survived for 15 months on chemotherapy. I think in the end, patient and their fighting, it matters.
I think one of the things that we are now learning is the role of stereotactic radiotherapy. So for bone and brain lesions, stereotactic radiotherapy, because we've always known that chemo-resistant and radio-resistant RCC, but for these metastatic deposits, particularly in bone and brain, stereotactic radiotherapy is another option that we have.
Thank you, sir, and that was the most enjoyable session.